Manager of Programs and Operations. I just wanted to start by asking how many of you have been to a 5 Points event before? Oh my gosh, most of you. Well, if you haven't, a little bit of background on the 5 Points series of events is that we learned from many folks like yourselves that there's a big gap between entrepreneurs and innovators and the traditional healthcare system. There was limited access to people who actually work within the payer, patient, provider, policymaker, and purchaser sectors. So we developed this to give you access to them, have some Q&A, and learn how, in this scenario, how health insurance actually works. Last year was a big 101, and then we had a 101 in January, a system-wide overview. And this panel is specifically about how innovation works and the role that health insurance plays in healthcare innovation. So thank you for coming. I wanted to thank the panel for taking time from their schedules to kind of up-level overall knowledge about health insurance and how the payer sectors work. And then I also wanted to thank Sina, our moderator, our entrepreneur moderator, for coming today. Last, I wanted to tell you about our Poll Everywhere. It's an online Q&A function that we'll be using throughout the program. So if you have some questions while they're talking, you just go to that URL and post your question, and Sina will bring it up. Without further ado, I'm happy to introduce Sina.
Hello. Thank you very much, Jessica. Hi, my name is Sina, and welcome everybody. I am a co-founder and CEO at Medsien. It's a early stage, a digital health startup based in Seattle, and we're trying to expand the access for care to chronic patients by minimizing providers' time and allowing the care team to jump in and deliver care to patients, and that is possible through a software care coordination platform that uses AI to automate a lot of processes in the care team. I'm excited to be part of this panel, and before we actually talk about the agenda, I wanted to ask how many of people here work with a payer system, just to get a general idea. Okay, quite a few. How many are entrepreneurs? Great. And how many work in healthcare innovation? Wonderful. All right, so we have a great audience, and it's going to be an exciting panel. So I would like to let the panelists introduce themselves and talk a little bit about payers' role in healthcare innovation and the impacts that they've had.
And I believe I get to go first. So I don't know if that's good or bad. So my name is Drew Oliviera. I'm a family physician by training. I practiced for about 18 or 20 years, mostly in South Seattle, more in an academic practice. I knew Bob, if you know Bob Crittenden. In our prior life, we did a lot of things in the family medicine department at the University of Washington. I have been with Regents BlueShield for about 7 months. I was with another carrier for 13 years before that. I think just to start with, we have an interesting thing in this country because we have a bunch of health insurers. And that's different than what we see in other countries, right? Some countries have health insurance, but it's sort of managed in a different way. It's more national health coverage, et cetera. And you all understand why we have the system that we have, right? So it's post-World War II. I get a vertical head nod back there, right? So you couldn't actually raise wages after post-World War II. It was against the law. So what did you do to kind of keep your employees happy and put them in there? You started providing them benefits. And that was sort of an unusual thing that happened. And one of those benefits happened to be health insurance as a benefit that you could provide, and pensions and things like that, right? So from 1946 into 1958, all of a sudden 75% of people were actually covered by their employers. And they were covered by something called health insurance. Now, when did health insurers show up? Well, our company has been around for about 101 years now. Did I get it right? 102 this year. 102, thank you very much. See, I'm still new. But a lot of it really began, when there was a need for it. So 102 years ago, did you really need health insurance? Probably not. There wasn't much that you were, using it for. You were pregnant, you had your baby at home, midwife came in, and thank you very much. But right around that time, you started seeing use of hospital services go up. You started seeing more. It was a little safer in the hospital than it used to be. There were surgeries that you could have. And all of a sudden, there was cost associated with that. So the great case study came out of Baylor and the school districts and the teachers there. And they said, we want to cover ourselves for future pregnancy-related costs. And they paid $6 for the year. In case they got pregnant, they could go to Baylor. And that was really sort of the start of sort of health insurance. And it really began on the hospital side. And the hospitals had a big Blue Cross on there. That should tell you why Blue Cross came up. And then physicians said we should do the same thing. And then they had a little shield, and those were the BlueShield plans. And so those things began, and it sort of just began, and it leapfrogged when, after World War II, and you couldn't have any other coverage. That tells you that these plans have been around a long time. They've done things the same way for a long time. And when you do things the same way from a long time, it's really hard to move the Titanic because it just keeps going in the same direction. That said, a lot of things have been occurring over time with health plans because now the consumers are different. There's more data available for folks, and people want they want to look at things differently. We also have a whole new generations of consumers. So, the silent majority and the boomers. Okay, we sort of dominated things. Now you got your Gen X, your millennials, and those folks want to deal with healthcare in a different way. So they don't mind not having a doc that they have to see face to face. They are more happy to do things digitally. But the other thing is you see that influence hits all those boomers and even the silent majority as well. So you're seeing a lot more use of technology and sort of asynchronous care, digital-based care. They want to be able to schedule your appointments just like you would, anything else you schedule, right? I want to go out to dinner. I got 1 minute. I do a couple things, right? I go to Open Table and I make an appointment. What they want to do is be able to do the same thing in healthcare. They want to have everything sort of available to them. They don't want to have 15 apps to use, right? They want to have one place to go. I want to be able to know what my condition is. I want to know who I should see. I want to be able to make that appointment. I want to get that appointment and check in and not have to share all my data with them because that data should be available to them as soon as I check in. And when I walk out, I want to be able to click a button and pay for that bill if I have to pay anything, right? That's sort of the experience that people want, and we have not delivered that on the healthcare side. And so payers are stepping into that type of process. How do we not only do that piece, but how do we nudge people for the right things that you should do? When you walk into Walgreens in September, I want to be able to know your claims, know that you walked in there because I'm geolocated on your phone. I want to say you did not get a flu shot. I'm going to send you a note that says you need a flu shot. By the way, do you want it right now? Click yes. They'll be ready for you in 2 minutes, and they'll give you your flu shot. Thank you very much, and you're good. Okay? That also gets to what do we do with data, and how do we manage data, and how do we manage the appropriate use of data? Because some of that sounds a little weird and scary. But for you guys in this room, you're probably going, yeah, absolutely. Let's just keep doing that. So to talk about data, I'm going to present.
To talk about data yet, but that is something I'm going to talk about soon. First, Lisa Murphy. I'm with Regents BlueShield. Our holding company is Cambia Health Solutions. We obviously sponsor the Cambia Grove. We don't usually like to have two folks from the same company on a 5 points panel. But the representative from Premera, Blue Cross, could not make it. So you got me. If you were here last year, you got me twice. Sorry about that. I have been with Cambia for 16 years. I've been in the Blue healthcare system in one way or another as an attorney for 26 years now, which means I'm not a millennial. I'm the old woman at the table, which is sometimes hard to deal with, frankly. But I also want my health care to be delivered easily and electronically, just like Open Table, so I feel like I'm a little bit with it. I am Deputy General Counsel, and I spend most of my time, and have since 2010, not working and supporting our health insurance company, so I don't give any legal advice to this guy. Would you take it? Yeah, that's what I thought. What I do is I spend time helping our startup companies and our innovations. We've had some companies we've started up over the last 9 years that no longer exist. That happens with startups, and we have some startups that have taken off. And I think a lot of that entrepreneurial spirit that was on our kind of non-health insurance side has come over to the health plan side. And, you know, we have a bullet point here is about what is the role of the payer in healthcare innovation. Payers don't have to have any role in health innovation, but do they want to survive, right? The system can't survive the way it is. The problem is it's so broken in so many aspects, it's hard to figure out which thread do you start pulling. If I had a magic wand and could change one thing and then wait 10 years for it to sort itself out, it goes back to something that Drew said, and that's employer-sponsored healthcare. Employers did a great thing after World War II by stepping in and setting up these benefits, but it has just, it's created dysfunction after dysfunction, including separating the consumer from the actual cost of care, and what they need to know to make the right choices in their cost and quality of care. And I'll talk a little bit about maybe some substitutions for that other than maybe tools that we have and that I'm sure many of you are working on. Should I give him back my other 2 minutes?
Give me back 2 minutes.
That's what I'm saying. No, anyhow, that's why I'm here and some of what I'll talk about.
Lisa, I think you gave me the perfect segue, so I'm like really happy. I know, I'm doing it. I'm Molly Moore. I used to work with Lisa at Cambia. I actually helped build the space that we're in, so I love coming back and talking with everybody and keeping everybody, just seeing how everything's going, keeping up with the cool kids, as I like to say. I've been in healthcare since 1996. I have played lots of different roles. I've worked for providers, I worked for payers, I've done consulting. I used to work for Jeff. And I'm super happy to be here talking to you as the health plan lead from Decent. Decent is a health insurance startup that will be using blockchain technology to administer association health plans. And the perfect tee-up is employer-based coverage. So not everybody has an employer. There are about 60 million people who are considered freelance workers. It's the fastest growing employee population in the US, and they aren't offered health care. They're either 1099 workers or LLC workers, but they file their own taxes. They have to pay their own corporate taxes, and right now they're buying mostly on the individual exchange. And legislation came out recently that allows them to band together as an association of individuals and use ERISA, so federal legislation, to get coverage. And so you can form an association health plan and self-fund it, which is a little bit scary proposition for some people, but it allows you to buy like a group and get group discounts. And so just really plainly, not a huge fan of a lot of other things that are happening at a federal level, but this actually does make it easier for individuals to buy healthcare coverage, provided that there are health coverage options that are fair and actually cover people and do a good job. So what we are essentially starting up is a Decent health plan. Haha, get the name. And my whole goal in setting up health plan operations and the way that we structure benefits, et cetera, is to get out of the way. I don't really want to do anything to do with care. I don't want to approve things. People hate it when health plans do that. And it doesn't result in better care. It results in frustration and physician burnout and all these kind of things. And so my hope is that, what's the role of payer in healthcare innovation? Right now, we just move money around as a payer. That's a lot of our function, is we take money in and push money out and take some of it, usually about 15%, as the administrative fee. And so really the role of health insurance is to move money around. It's, in all honesty, like there is going to be innovation there, and the health plan payers have lots of money and lots of responsibility and lots of risk, but get out of the way is my whole goal. And try to encourage innovation, encourage patient-provider relationships, and kind of do what's right. And I get to do that because we're starting from scratch, and I don't have to sort of fix the airplane while we're still trying to fly it. So that's an insane luxury that I get. to have in my daily life is I kind of get to dream big, and I don't have a lot of constraint other than regulatory, which is insane. That's why I love you, Lisa, so much. Innovations that have made an impact is another bullet point that we should talk about. Telemedicine is one that I think is mass underutilized. I love access, convenience, et cetera. That really is sort of the millennial way. And 2 years ago, when I left Cambia, the adoption rate of telemedicine, et cetera, was like under 5%, and now it's somewhere in the low teens. So it's gained massive adoption, and that is something that I think is great. I think there's sort of back to the future innovation that's happening. So like old school primary care, which I'll talk a little bit about later. People do want to have human interactions in their care. It makes them feel more comfortable. We did a bunch of surveying and found that freelance tech workers, they actually still do what their doctor says, even though there is lots of consumer information available on Dr. Google, what have you. And so I think some of the innovations that we'll see that are, sort of forward thinking are actually like, hey, let's get back to what really matters and start focusing on the patient and just get out of the way of good patient care. So I'm Molly, I work for Decent. Okay.
Talk about the agenda in the beginning. So we're going to talk about the role of innovation, role of payers in the innovation, and the impacts they've had. We're also going to start talking about some of the trends that are coming up in the payer systems and what are the barriers to adopting those trends. And also we're going to talk about the high priority needs in the end, and it's going to be a good discussion. I did get a few questions over here. I try to summarize all of them into one since we only have a few minutes. So when we talk about innovation coming from payer, I mentioned different areas of discussions, and mostly it is very difficult within the system because it's been used in the same way for 100 years, and there is a lot of effort internally. But what is the role of entrepreneurs? What is the role of innovators from the outside? And what is that dynamic look like internally and externally for a payer system to try to innovate and change this system?
I'll start, and then Lisa, you can jump in. How about that? Because part of the role of the health plan, yes, we move money around. We also try to provide sort of quality providers for members to go to, right? So we vet them, we credential them, whatever we want to do. We try to also get a better price than they would maybe get on the open market. That's sort of some of the basic function. The other piece to that is we also want to make sure people are getting the right care at the right time. Staying out of the way is one thing, but some things you might want to get in the way of, especially things that are overused. So we will do that, and that's a friction point, and people will go, well, my doc says I should have this weird experimental treatment that doesn't work. Shouldn't I have it? And we would say, no, it doesn't work. And then they get mad at us. So all that stuff happens. But when we look at the population, we're really looking at the full population. So traditionally, I think a health plan looks at the top 1% that costs 50% of the cost, right? And that's just what they've traditionally done. But the other 90+% of the people, you want to keep them as healthy as possible. And we can only do so much, right? So we can have a case manager. We can help some of those really sick people navigate the system, get the right care, and things like that. But how do you do the things that actually impact longevity? And the things that impact longevity are really sort of in three buckets. One is your genetics. So Kaiser Foundation said that's 30% of your impact. So if if you're going to live long and you have great parents, thank them because they're probably still alive. Number two is medical care, and that's about 10%. So that's the impact to longevity is medical care. And then the rest of it is behavioral. So it's your lifestyle choices and where you live and sort of society. And health plans, I think the sweet spot that falls in there is what about that behavioral change? How do you make people do what you're supposed to do? For those of you who are clinical out there, when we would take care of patients, we would say, here's a medication to take or whatever else. We didn't have enough time to talk to them, so they didn't understand why. They go, we see them again in 6 months, and we say, how'd that medication go? Yeah, I didn't fill it. And that occurs about 50% of the time. And we never knew. right? So health plans have started collecting data from the pharmacy to say, okay, this person didn't fill their prescription or didn't refill their prescription. We need to message them and tell the doc that too. So you can start using data back and forth. So that's, one piece. I think where people have the opportunity is to fill those gaps that we have. So where are the gaps in care that are not sort of the big broad ones, but sometimes they're very specific point solutions, maybe for a specific condition, maybe for a high-risk area, maybe for something that's traditionally been done, but no one has really addressed, right? So expensive treatments like muscular sclerosis. You've got very expensive medications. The docs go out there and they prescribe something. You don't know if it's going to work for 12 to 18 months. And then when it doesn't work, then you use something else. And so the idea is, how do you get ahead of that one? Can't you figure that out in 3 months rather than 18 months and put them on a more appropriate treatment, before you've done this sort of trial? Those types of things I think are places to get. And then how do you actually nudge people to give them? I gave you the nudge, right? With, you walk into Walgreens, I nudged you. That's a really cool thing. And you might actually do something, but you may not.
Yeah, but then how much of that is internal and how much of it is external? Where are we going to find these innovations? This is all great ideas. And then, first of all, why do it have to be so complicated? But now that we know they're complicated and hard things are hard, where do we go to look for solutions? Do we go to the outside, or do we go internally and try to find the answers?
Well, I'll just keep talking because that's what I do.
How about I take that one?
You can go.
So I'm a firm believer that innovation is awesome. I think that the energy and the technology that's being poured into healthcare right now and probably over the last 10 years is amazing. Like, would you have ever thought that you would be in healthcare innovation? Like, probably not, because it's been a difficult industry to be in. It's hard. People are sort of game for solving hard problems right now because it's at a pretty critical point. And one of the things that we are employing as we're building our health plan is that why build it if it exists already and it's good? And so there is a lot of value in essentially stacking best-in-class solutions together. And it's different at an established health plan. How do you measure best in class, and what's the return on investment, and who's the best fit? And you have to do vendor management. And again, I have this massive luxury of not having those sort of corridors I have to walk through. But there are tools out there that help make better clinical decisions, that help manage patient populations better. There are like hundreds of them. And really finding the one that's the best fit for your company and for how you operate, there really is, a lot of stuff going on. Things will float to the top. Pretty soon people will start to figure out who the best in class solutions are, and those will start getting widely adopted, and then you'll have critical mass, and then things will take off. So the role of innovators, I think that was the question, is to keep pushing us, is to keep pushing health plans to think about things differently. One of the things that I learned when I worked for Cambia and did business development for the startup portfolio was that it took 18 to 24 months for an innovation to actually make its way through a health plan. And that's just sad, but it's a reality. And so innovators, but one of the things that was happening was that the decision makers had to hear that this was a thing they needed to actually invest in at the right time, to put it in their budget, find an executive sponsor, and get it all the way through. And so even if it's not you that wins, it will be a peer, and it will move that innovation forward. So please keep pushing each other, and please certainly keep pushing health plans to hear that there are innovations, there are different ways about to measure success and go about addressing patient needs.
And Sina, you added to the last part of the question, internal innovation or external innovation, and why? And Molly hit upon it. Like, she's talked about, I don't have these limits. I'm in a startup. And that's really true. I'm not saying startups can ignore the law, but you don't have 14 attorneys to help you understand all the nuances of the law. And frankly, if you get it a little bit wrong, you have time to fix it. And if you can't fix it, well, you haven't just taken down a $9 billion company, right? Our company, people bring things to me that they're building internally, and I put a few attorneys on it, and there's a long list of all the things we have to worry about. And that slows down innovation inside. Now, we know that, we work on it, but nonetheless, if we're going to take a risk, my risk tolerance when I'm giving advice to innovations within Cambia is pretty low compared to when I'm giving advice to some of our startups. It's never, this isn't about don't follow the law. It's in that gray area. Where can you accept that risk? So that's why external startups are critical. And I agree, the onboarding process is very hard. I think we've gotten better at it. I would like to say less than 12 months, but I probably can't. A lot of people to convince in a big company to take on something new, including this guy, by the way. Is it not true? Right? We have to convince a lot of important people.
Not me.
You. In any event,
I'm easy
it's
to
important to have both, but I agree. You need to do your innovation, find that space, collaborate, find out about the healthcare systems, and you can maybe even want to know what the 9 months is on. Working with folks at the Cambia Grove, frankly, is a good way to do that because they have these.
But isn't part of the problem with us being in health plans is that we are traditional and we are risk intolerant in general. I mean, that's what we've been doing. We've been managing risk, and now we're being asked to be innovative and do something different and step where the unknown is, right? So I think that's probably why it takes so long for us to implement certain things. I'll just say from my standpoint, when I look at things, I look for the gaps that I have in there, and then I will actually go to our investment arm and say, here's where I have a gap. Can you find someone who's doing something in that area? Because we just we're having trouble managing it. So it could be like if you think about a whole women's health portfolio, but you want to get really specific, and you say elderly women have an issue with isolation and actually abuse, right? So is there an innovation that we could think of that could somehow help in that piece? Not traditionally a medical plan piece, but clearly that impacts health. All the way to how do I get people, preconception and help them have the healthiest babies possible before they've actually even started to get pregnant, and whatever spectrum might be in between. So as we start thinking of, and I don't have solutions for either one of those, but those types of things is what I try to look for and ask those questions. And if people want to ask us those questions, yeah, by all means, we can sort of probably give you a list of all the holes we have and that we see in the system. And it could be our system, it could be the provider system, right? Because we see that as well. And Molly, you talked about telemedicine, right? And you said telemedicine's great. I think it actually is, right? And it solves a lot of problems that we see on the provider side. We don't want to bash the providers, but they're full. So if you think about behavioral health services, right? And behavioral health services are great, really needed, underutilized, and most of the providers in the community are full and it's hard to get in. So it may take you 3 months. I'm going to be really crying for 3 months if I can't get in to see someone. If I can use telemedicine services, I can do it in the comfort of my own home or my car or wherever I want to do it. I could probably do it any time of the day, and no one has to know that I'm seeing, a therapist, and and I can get the care that I need a lot faster, right? So those types of, more convenient type care, I think, are really important, and bringing stuff into the home are really important.
Right. You mentioned in the last bit that, come get in touch with us, ask us questions. Somebody asked here that how do they get in touch with payers? There are so many gatekeepers, there are so many layers in every particular system. And so how do innovators get in touch with payers?
So I'm going to give you a business development hack. Here's my business development hack. Go to the news page of a payer and find the email configuration, first name dot last name or first initial dot last name, and then email every configuration of that of the person you want to get in touch with. Some of them do. especially if it's on their list and it seems interesting. And don't hit them with marketing content, by the way, like dear sir or dear madam. Like that isn't going to work. Know your customer, but you can actually reach somebody by backing into the email address.
What is beyond the email?
Okay.
So you email someone, they might get back to you, they might not get back to you.
So this is really, I only did this for I did this for a while. So so I was just talking about this yesterday. Has anybody read the book The Martian and seen the movie? Yes. Solve one problem at a time. First get in the door. And then talk about your product in a meeting. And then get a second meeting. And then figure out who your champion is. And start figuring out what that person really needs. There's all sorts of things. But getting your foot in the door, that's the biggest thing. So after you get your foot in the door, solve the next problem.
Great. So let's shift gears a little bit and talk about trends. So Dr. Drew, let's talk about the trend and the barriers more importantly. So what is the trend that you want to talk about, and more importantly, what are the barriers to adoption of that trend, and what can we do about it?
So the thing that I've been, as a practicing physician, I thought I was doing a perfect job with all my patients, and I, assumed I was doing great quality until I started measuring it, and then realized I was pretty average. We also focused a lot on access to our practice, because what we realized was it was taking 6 to 8 weeks for someone to get an appointment, and we had to change that. So we had to innovate as a provider group to, go from a 6 to 8 week lead time to a same day lead time. So we were able to change our practice. It took us about 4 months of actually seeing more patients a day to work down that backlog, but we were able to get to a same day appointment for any reason that you wanted to be seen. It took the patients about 9 months to realize that we actually did that, because they would call up and they would say, oh, I'd like to make an appointment for a physical. And then the person on the other line says, would you like to come in at 11 or 1 or 3? Because those are and they were just, it sort of freaked them out for a while. They said, not so fast. Like next week, how about that? I was thinking 6 weeks from now, like normal. What's happened over time, though, is people have really wanted alternative ways to get care. And as we talk about telemedicine services, in-home services, if you're a frail adult and you can't get to the doc's office, it's really hard. I remember seeing a patient that she'd come in, she was just like death's door every time I saw her. And finally realized that maybe I should just go to the house. So I did a house call. She was fine at home, but by the time she got to my office and, someone got her in a car, she had to walk through this stupid parking lot that was too big. By the time she was huffing and puffing and just looked, it was killing her. But at home, she was fine, right? So how do you get in-home services? How do you bring those types of services to the home? Those types of things we're starting to see more, and we're seeing people actually be more comfortable with doing those types of things. In addition to just, other ways to get, rather than traditional care, like asynchronous care, right? So, I need to talk to my doc. I'm too busy right now. I'm multitasking. Although I'm not multitasking right now, which is shocking. But I don't want to actually have to wait on the phone and do things. I want to just be able to text them or email them or one of those things, and then they can get back with me in an hour, because it's not that urgent, right? Maybe it's a refill for a medication. Maybe I need some lab work done. Maybe I want my results, whatever it might be. People are increasingly comfortable with use of technology for their own data and for their own use and how they want to use it. I think we're going to continue to see those types of things occur. And then I think the other question is, and you mentioned it, the Dr. Google thing, right? What's wrong with me? I think I'll Google it. Oh my God. You get you get sort of this uncurated, hodgepodge of stuff. So people really want to know, what should I really do? And who do I really ask when I have something that's either life-threatening or really complex? And how do I get an expert medical opinion when, I think my doc's pretty good, but I'm not 100% sure, but who do I go to next? And where do I go? I think those are questions that come up all the time.
And what are the barriers to that? Why can't they get done right now?
Well, I think providers are either full, their practices are full. They have old scheduling systems that make them full. I think from a behavioral health standpoint, there's just not enough. So they tend to have full practices, and so they close their practice. They just can't see any more people in the traditional way. And they haven't adopted some of the new technologies in terms of, maybe I don't always have to see the person, right? And when you think about it, you go, well, yeah, this is a diabetic. I just need to make sure they're taking their meds, see what their lab work looks like, but I don't need to touch them. But I don't get reimbursed when I don't touch them. So I have to make them come in. And that, I think, that's a big barrier. And I think as we look into more value-based contracting, that from the health plan side, we can see them actually say, I can do a more telemedicine visit. I can do something else that's different and get the same quality and maybe better quality because I can touch them more often.
Let's talk about value-based a little bit. Molly, what do you think about the value-based care and the role of innovation in that?
Okay, I have strong opinions on value-based contracting. I'll talk a little bit about, so what I was going to talk about in this section is direct primary care. How many people know what direct primary care is? Okay, here's the deal. It looks a lot like CAP. So for those of you who've been around for like the last 20 years in healthcare, there was this thing called capitated payments, and you would pay your primary care physician or the whole system. If you were like in a Kaiser, you'd pay them a fee to take care of a patient. You'd get paid that fee no matter what happened to that patient. And it did all sorts of weird stuff, and this is one of the reasons that HMO sort of had a hard time. Did not work at all in the mid-90s. So, but what has happened now is primary care physicians who are like incredibly burnt out from seeing, how many patients would you say you saw a day? 24 patients a day. There's burnout. And so instead of completely bailing on healthcare altogether, they start practices where you essentially pay a monthly fee. You as a human, not your employer usually, pay a monthly fee and you go to your doctor. And you have your doctor's cell phone number, you have their email, and there is no fee for service. And it's awesome. And the whole idea of population health management, intervening with really sick patients, making sure somebody took their meds or got their flu shot, it's done by a clinician that you know and spend time with. They don't spend 8 minutes with you so that they can bill a 99213. They don't have fee-for-service billing. They don't have productivity they have to meet, etc. So they are 100% incentivized as a person-to-person relationship. There's a customer service element associated with that. There's a follow-up associated with that. They don't want to see you if they don't have to. They want you to get the best deal, too, when you leave. So they refer you to people who have really good care, bedside manner, etc., and that produce good results because they take care of you after the knee replacement. They take care of you after the back surgery. They take care of you after your physical therapy. So they are sort of your quarterback of care. And that's the holy grail of care management, is actually physicians engaging with patients who are sick and need to be managed. And as such, you drive down healthcare costs because they don't go to the specialists all the time. And unfortunately, in primary care, it's I see you for 8 minutes, and if I can't resolve your problem in 8 minutes, I'm going to ship you off to a specialist who you're going to pay 3 times the amount for, and they're going to see you and prescribe you a medication. And then I'm not going to hear about what happened ever. That's what happens today. So value-based contracting is supposed to sit over that at a health plan level and say, hey, you primary care physician who's seeing 25 patients a day, we're going to give you an upside spiff if you do a good job managing your 2,000 patient panel. How many physicians do you think even care about that? Like, do you have time to even think about that? Well, you better, because you're employed by a group who wants that upside risk sharing. Value-based contracting is rough. And it's like in its infancy, despite what other people say. It's just really not. I did a value-based contracting, I will tell you this because I worked at Regents. I did a value-based contract in 2008 with Multicare Health System between Multicare and Regents. And it was the very first one, and I'm like doing math with actuaries on the board about how we would calculate whether they hit the things or not based on if the patient population size changed and all this stuff. And it was awesome because it was focusing on the right things. It was focusing on maternal health, driving down ER usage, and all this other stuff. And I was like, yes, this is it. We're finally doing it. We're pulling all these other levers, and they're going to be healthier, and the people of Pierce County are going to be so happy. And like in 1 year, they couldn't change enough of the process inside the hospitals to actually make that happen. And so then we had to do it the next year, but they didn't achieve the first year, so they were pissed. So they needed more. I mean, it's just kind of like this round robin. So I have strong feelings on value-based contracting or on value-based payer plans because I think the answer is just make it simple and get out of the way. That's what I think.
I have a question, not
Yes,
about
ma'am.
value-based contracting, because we could, that's a hard hill to climb. Direct primary care, I used to hear it as concierge care, but let's assume it's a little different.
Yeah.
I think that works if the employer's out of the way, but maybe the employer can be involved. How is your plan implementing direct primary care?
Yeah, so we are only contracting with direct primary care. So if you are a primary care physician and you would like to work with freelance workers in Austin, Texas, we're launching in Austin, Texas, you will need to not take fee for service. And this is for a number of different reasons. One is that it nets better care. The other is that patient satisfaction with these types of physicians are like 5 out of 5 stars. And I will just tout our awesome primary care physicians in Austin, Texas. You can look at their reviews. Melissa Miller is one. Dr. Chris Larson is another. Dr. Chow Nguyen and his partner, Dr. Vega, and Dr. Katrina Iqbal. And if you look, people love this style of care. And one of the things when we were contracting with them, they said is, we don't want you to have a role, basically. Like, our relationship is directly with the patient. And so the contract that we wrote, this will just make you cringe, I'm so sorry.
I doubt it.
Is 2 pages long. And it says, we will pay the fee that's listed below. And you agree to maintain your licensure and all of the things that you need to do in order to be like a legit physician. But we want no role in this, despite the the fact that we're paying. We essentially want to back out of it. And then they have a direct contract with the patient, and it's a physician-patient contract. And if that contract is broken, then the physician can fire the patient, and the patient can fire the physician. And so that is the level of patient innovation care that we're supporting. So that's how we're just doing primary care. And the barrier to that innovation, since I'm just probably not going to talk for my second 5 minutes, the barrier to that innovation is the ability to scale. And so Cambia Health Solutions, the Direct Health Solutions, or Echo Health Ventures, invested in a company called Qliance. They were local, amazing company, and they scaled up and were venture backed, initially backed by Adrian Hanauer and Jeff Bezos. Cambia, as an investor with a venture capital arm, came in the C round, and they started to scale. And they started to work with Coordinated Care Centene, local company, and they took on 30,000 Medicaid lives. And so they built out this huge infrastructure to serve the 30,000 Medicaid lives, and then the contract fell apart with Centene and Coordinated Care, and they had sort of outlaid all this capital, and so it just came crashing down. It was not a good day for any patients who were seeing Qliance, because they also had ridiculous satisfaction scores, and people loved them, and they were now all over the Puget Sound from Tacoma to Linwood. But the model has like war stories, and people have like scars forever about trying to grow direct primary care too fast. So the barrier to innovation there is really the ability to scale physician practices and expand physician practices is capital intensive. And so being able to scale smarter and faster is something that we're working to enable for direct primary care as we expand in the state of Texas and to other states and potentially internationally.
Yeah, so we started by talking about the role of patients and personalized delivery of care, and then we started talking about value-based and why is it better that providers don't have to have you come in so they can get paid. And then we got to primary care, direct primary care. And then I have a little question before we move on to the next topic about direct primary care. A lot of the implementations currently about direct primary care is kind of this additional on the side with your employer's insurance already. And the pitch is that it helps you with your deductibles if you have this plan on our practice. And I wanted to get your take on that in terms of the contrast between direct primary care and the value base that you talked about. But why can't payers, sponsor the direct primary care? Why does it have to be a subscription model that all the consumers are used to?
So there are a couple of reasons. I try to do this at Regents in 2013. They removed their ability to pay patient management fees. And in order to, there's all sorts of implications of bringing direct primary care in the network. So if you credential all of them, most direct primary care opts out of Medicare. That makes it difficult. They shouldn't be available. People can't off the street can't just go see them. So there's a weird designation that they would have to have in the provider directory and all sorts of weird stuff. So the short answer is they can. The long answer is it's really hard because it's square peg round hole. The other thing that we were finding as we were talking with people who use direct primary care is that they were more than willing to double pay for primary care. And I think that's crazy pants. But they loved the care so much that they were really willing to pay, their insurance premium plus their direct primary care. And direct primary care is getting pretty savvy about leveraging sort of wraparound health insurance. And so, when we talk to direct primary care, for us, they're just like smack in the middle of a patient's sort of care continuum. And we say, listen, we're trying to build the ancillary services around you, and we'll pay you your fee, and then we'll pay, for the other thing. And they really love that because half of their patients are generally uninsured outside of direct primary care. So the second thing that makes it really difficult is, we'll help you with your deductibles, but you cannot have direct primary care be part of your health plan and contribute to an HSA account. So they're working on this at a federal level. When you have an HSA, if it's an HSA eligible account, essentially there can't be any, and you could probably speak to this a little bit better, but there can't be any upfront payments, basically.
For kind of a certain list of benefits.
Yep. And one of those is primary care. And so it's not HSA eligible. So you can't do direct primary care plus a high deductible plan with an HSA to sort of cover the gap. That is the best benefit design, but it can't exist right now because of legislation. And so if any of you know or want to write to your congresspeople, and if you're like me, you sort of know their address by heart at this point. But the idea is that HSA should be eligible with direct primary care, and there's a whole lobby essentially that's working on that. But yeah, that's why there are two reasons.
The other thing that we've seen is there's a pure direct primary care where you're paying whatever $150 a month or whatever it might be, and you get all your services. The other ones that we've seen is do a hybrid, and so they will still. The fee may only be $150 for the whole year, and then they will build fee for service on top of that. So that 150 is a little easier entry. They still practice almost the same way. So they still do telemedicine visits and everything else. They have much fewer office visits than a typical practice would, maybe 12 a day, but they may also have 20, telemedicine visits during that day. And
And that's how One Medical operates, for those of you who know One Medical Group.
And employers will then say, outside of the plan, if you want to be part of that, I'm paying that upfront fee because I want you to go there because you can have a better experience and probably lower costs, and then they'll measure it later. But they'll pay it outside of the plan to sort of get away from some of the dumb things that we do as plan people, right? And so that's another way to kind of get that that type of
An additional service on the side. Yeah,
So I think
absolutely.
we're going to see more and more of those hybrid type of things.
Yeah, the hybrid model could work. And now, since we're on the topic of, talking patient preferences, Lisa, why don't you share your thoughts about patients' role into working with payers? And, we talked about data that is now accessible, that exists right now, but it's not necessarily accessible. So what is the patient's role in all of this, and your take on it?
I like Molly's, she says, get out of the way. I feel like the healthcare system needs to get out of the way between where a consumer's data is and getting it to the consumer. If you've ever tried to go to your health plan and get your data, it usually goes to the private. I mean, this is all laws are well-intentioned, right? But then there are all of these asinine results, especially since, even HIPAA, which was, enacted in 1996. I mean, think about how much our world has changed. So we're trying to comply with all of these old laws, and, we're trying to do our best. And then there might be some people who use those laws in a way to block change because change is scary for them. I would like to say my view is not Cambia. So in any event, you want your data. You go to your health plan, or maybe even go to your doctor and say, I hear I have this right under HIPAA to get all my data. They're like, okay, well, we're allowed to charge 12 cents a page, and we'll copy it all, and we'll send it to you, in whatever the time limit is. And you get it, but that was good the day they copied it, or at least the last day you went to see them before that. What if a customer wants their data to be sent to some startup, online, or app, and they want it real time or at least daily? Are you going to send a paper request to the health payer, to the doctor every day? Like, yep, we want it again. Any updates, any updates, any updates? So there's a ton of work in this area, and I know many people in this room probably, if I say API or FHIR, F-H-I-R, you know what it means. I just kind of say the words, and people on my team kind of explain it, and then we put it in 14-page contracts, not 2-page contracts. But the idea is to get data from the payer system, from the provider system, from maybe slightly evil electronic medical records companies who, data is valuable. They need to, we always think someone else is evil. People think we're evil, I got it. They need to figure out how to get this data into the hands of the consumers. There was a tweet I saw last week from one of our board members who, at Cambia, who's focused on this. And the tweet was about a mom at the doctor's office. Her son had a CAT scan, and she was filling out a form to get the results, and they actually had a line that said, reason for request. And she wrote, because it's mine. Like, why do I have to justify needing this? And of course, she was getting the results just probably handed to her in an envelope or sent to her by an email, not in this real-time way we need for people to be able to manage their own care. Then you think about managing the care of your children, which is a little bit easier because in the system we know they're your children, and hopefully, if they're over 13, they've given an authorization that somehow you've sat down at the computer and had them poke the right button, or you just did it. So you can get their data. But what about parents or elderly friends, right? How do I help my mom, who is 75 and is, recovering from a stroke? Frankly, at 75, she will always be recovering from a stroke. I work at a health plan, and I have a hard time figuring out how to help her get all of her data, be able to communicate with her providers. We just need this liquidity of data, and we need it now. Now, the federal government is doing some really great things in this area. If you guys are in the Medicare world, you know about Blue Button. I remember when the team I support started talking about Blue Button, I was just like, what is it? It's data liquidity, and they're requiring payers in the Medicare Advantage system, not traditional Medicare, where it really is healthcare financing, to set up the system, the APIs and the FHIR data transfer, so that can go to a system that somebody has set up online for that person to manage their care, or hopefully for maybe a relative to manage their care. And we are moving into blue button in the commercial space too, which is desperately needed. So that's a trend. I think, again, a barrier is maybe some companies not wanting to do that, either because the data is their that's the valuable resource, or it's costly, right? If you haven't started building your APIs, you're behind. Just another trend I wanted to mention is peer health advice, right? Ever since Dr. Google came around, we're looking, maybe it's Mayo Clinic or WebMD or, maybe high dose vitamin C therapy for cancer that we might learn about, whatever our search brings up. But really, we're trying to figure out who has my problem, right? My husband just joined a Facebook group that is for kids with allergies going to Disney, right? And by the way, Disney's excellent with kids with allergies, and we always knew that. But then, the stuff you learn on this very active Facebook page, in a way is peer health advice. And Susanna Fox, who is on our board, has started a consulting practice and really an advocacy and practice or process of trying to get people to understand the value of peer health advice, as opposed to just you talk to your neighbor or you saw something on Facebook or on Google, but to actually figure out if there's an evidence base for peer health advice. And I just love that, because we always trust what we hear from our friends more than we trust what we hear from our doctor sometimes. Sorry. You've experienced it, right?
All the time.
Right. And I just think that that's a fantastic idea, and it's, crowdsourcing medical care. And I think we need more of that, and that's a space where folks need to innovate as well, because let's face it, we don't want to be doing it on Facebook, because privacy does still matter, even if people don't care about their privacy as much. It still matters. And then the very last thing I'll mention, and this is not an area that I'm an expert in, but I think it's so interesting. Drew, you mentioned the elderly woman who needs care in her home because it's hard on her health to even get to the physician's office. Just the idea of social determinants of health, whether in the elderly or in our system. The 60% you mentioned of how we take care of ourselves. Yeah, we all know, don't smoke, don't drink very much, get lots of sleep. How much of, do we do it? I don't know. But there are sections of our population, if you say eat more fruits and vegetables, they have no way to get fruits and vegetables, right? We all know this. How does the healthcare system play in that? We have to figure out a way, right? We can't, we wouldn't be able to fund, and we wouldn't want to be a country that funded everybody getting a box of fruit and vegetables at their door because everybody's worried about socialism and communism. So, but there has to be something in the healthcare space, healthcare adjacent, where we are trying to solve those problems. And I know there are a lot of folks trying to solve them, but I feel like that's something where we actually would have probably the biggest impact on healthcare outcomes.
Yeah, this is a very, very interesting area that allowing patients to have the decisions to what they want to do with their data or how they want to be cared for. It's a very sound idea, and then we're sitting here on a payer panel that we cannot figure out who's here to blame, and it's definitely not payers, it seems, but it could be anybody. And this is it's partially payers, but it's also partially, that's why we have the 5 points. It is partially every other P, and it's up to the audience to say, to decide which P has a bigger impact on it. But it's really interesting that allowing patients to have choices on their own data or on their own care is really important. And I do have a lot of questions, but let's open it up to the audience for 1 or 2 questions before we move on to the high priority topics.
Molly just talked about the coordinated care organizations. So some of the innovations being forced on them is to cap their growth, the expense growth. For example, in Oregon, they're only allowed to grow by 3.5% or something, although the actual healthcare expense is increasing by more than 5%. Are the payers like you trying to learn something from them or trying to innovate the way they are being forced by doing things that they are doing?
Are you saying, I'm sorry, are you asking a question, are we learning from the mistakes?
From Medicaid and Medicare innovations that are being forced in indirect way because the government is just capping the expense that they are paid?
Indirectly, yes. I mean, most providers who provide services to anybody in the commercial space also provide to Medicare and Medicaid. Most. Some more than others. Harborview versus Evergreen Hospital locally, there's a big difference. So the money constraint and the innovation that comes on the provider side from either a loss or an increase in revenue, depending on how well they're doing in value-based contracting, other commercial payers either benefit or don't, because you can't, if it's one thing I've learned, you can't change how physicians practice from one payer to another, and changing how they practice, period, is very difficult, but getting them to acknowledge that this is a Medicare patient versus a commercial patient. So the Medicare and Medicaid innovations, and that just bleeds over onto the commercial side. They're indiscriminately seeing 24 patients, 26 patients a day. They don't know who's kind of coming in. So yes, indirectly is the answer to your question.
I think your question is really about, sort of global budgets and the fact that a global budget can only go up by a certain percent, and the healthcare costs are going up 2 times that, right? So that's why you're starting to see, some of the innovations for less expensive care, dyssynchronous care, text a doc for $10 a month, right? And that's cheaper than going to see a doc, 3 times a year, right? So you start seeing those types of things to kind of just, beat around the edges. But the real big cost for healthcare, I mean, it's, specialists drive 50 to 70% of the cost. 12 specialties do. It's not typically primary care that's gonna save you. Hospitalizations have continued to go down over time, but where do we see the big costs? They're in things that are harder to control from a unit cost standpoint. Specialty medications and things like that are super expensive. Really good, great innovations, right? Hepatitis C, I mean, if you had that and you got a hepatitis C drug and you're cured, my God, 5 years ago, that wasn't an option for you. Now it is, and unfortunately it came in at, $84,000 to $95,000, a little less now, but not much. So, go overseas and get it done for $3,000, right? So that's just another problem. But I think, we continue to force ourselves against that. Innovations and technology adds about 2 to 3% to the medical cost trend every year. Age, every year you're older, adds another 3% to the cost. I mean, there's a bunch of factors. If we just stop getting older and maybe that would help, but we don't do that. So, a lot of people would tell the elderly, your best thing to do for your healthcare costs are to stay in as good a shape as you can your whole life. And, if you're going to start at 65, do it at 65, because you're going to be less likely to fall. You're, might be able to control some of your chronic conditions a little bit better. But the providers don't think about the global costs. And I was just with one, before coming here. They say, I think we're more expensive. And the answer was, well, duh. And then but we don't know what to really do about it. And we're not sure we really care. Because in a fee-for-service world, they're like, if our unit costs are higher, we're okay with that, as long as people keep seeing us. And until people don't see them anymore, they're going to be happy to get that. So they don't think in the global way. And then we try to do weird things by not sending people to them, or negotiating with them for a better price, all that stuff that health plans traditionally do. But
Yeah, that's a great note to start speaking about high priority needs. So let's have a discussion about what are the short-term high priority needs right now, and if each one of you can share an example of some of the successes they've had doing something, or making a change in this arena, that would be helpful, and kind of gives the audience a pathway to not only what are the needs, but how are some of the examples of us getting there.
Okay, mine are going to be totally unrelated. Mental health is a high priority need. We don't have a shortage of clinicians, but we have a shortage of bandwidth at those clinicians. And a lot of behavioral health, mental health, et cetera, manifests itself in physical symptoms. People who have anxiety, they go to the emergency room for shortness of breath, et cetera. And I think that we're doing an okay job as a society, starting down the path of saying, I have a condition, a mental health condition, and talking about it. And unfortunately, it's as a result of people who have either committed suicide or overdosed on drugs accidentally that we're now having this conversation. But addressing mental health in a community, in an employer, in a however you want to address it, there's a bandwidth issue, and I would love to see that happen. Before I started working at Decent, I worked for a Taft-Hartley trust locally called SEIU 775, and SEIU 775 is there's 50,000 home care workers, and they are often isolated. They're often self-employed, and one of the things that we dove into from the day that I started there was figuring out how to get them better mental health care. And the wait, we made Group Health, who was the carrier at the time, track the wait, and it was not good. And so what we did was give them an app called Ginger.io, and you could text the app, and people used it. Some people used it, some people didn't. Some people were pretty leery of their union or their employer giving them an app that tracks behavioral health, and I totally get that. And we tried to work on that, and I left, I think, before that was really completed. But getting people tools that they feel comfortable using to address behavioral health, getting people the care that they need in whatever capacity they seek it. I really think that's a game changer for most communities. It has a lot to do with social determinants. Like, if we can fix that, I really do think that, society as a whole and the general overall healthcare costs would go down. Yes. So the question was, we don't have, my comment was, we don't have a shortage of clinicians, we have bandwidth issue, and she asked me to clarify that. So a lot of clinicians do not take health insurance, and they just don't, because they don't have to, and it's $130 a visit, maybe. So if I'm a person who makes $15 an hour and is trying to afford my Seattle rent, that is like $130 a week to see a therapist for an hour is not in my budget. So that's what I was talking about. It's the financing piece. Well, and it's in providers' willingness to sort of be in that fee-for-service model. It's a churn and burn type of a thing. If I'm a single psychologist, I have to employ one other person just to do my billing and reconciliation, or else I'm doing it myself. And most of the time, that isn't worth it. Yeah.
So high priority needs that need solutions now. I will say two. One I touched on, and I'll save it for number two since it deals with the law. The other is just provider costs. And that you don't want to take any part of the healthcare system and demonize it. And I love my providers. But we manage health insurance companies, and we look at their costs. The health insurance company costs, Molly said 15% was admin. I think we're closer to about 10%. And for a lot of insurance companies like ours, we are a nonprofit. Over a 10-year period, we have zero margin. Who's in a business and say, yay, zero margin? That's what we do. We also pay taxes. This isn't about us. But the point is that we are financing the health care. Our cost to our members and our employers who are paying for insurance is 90% provider cost. That's why we do get in the way. I love your model, by the way. But that's why we do get in the way, because the only way we can bend that curve is by trying to control that cost. We need to figure that out. And we can try value-based care. We can, try to change the fee for service system. People have been working on this for decades, but we need to figure that out, or the healthcare system isn't going to change. And then the other thing I would say, related more to innovation, is changes in the laws. I mentioned the laws are behind where we need to be. Just as an example, I wouldn't say this is like something that I would want to change immediately, or I'd be writing to my congressperson. But what I would say is there are ridiculous results from, for instance, HIPAA. And here's an example. Regents customer service gets a call from a member. The member's talking about her health care claims. But then, you know, it's not just a one and done. They enter into a conversation, and maybe the member's talking about how hard it has been to lose weight. Doctor keeps wanting me to lose weight. I can't lose weight. Our customer service representative, the legal advice we have given is you cannot tell that member about Weight Watchers without a HIPAA marketing authorization. How ridiculous is that? We don't own Weight Watchers. Good thing. They just, you know, the stock just went down. But anyhow, now it would be, I could see a protection there if we were saying, oh, go to Q Lions when we used when we owned part of Q Lions. But those are the kinds of things, and that's just a small example, where the current laws on the books just don't work. The laws are getting in the way. As much as I want employers to get out of healthcare, they're not going to in all sectors. The federal ERISA laws get in the way of employers being innovative with their benefits. I see it time and time again as my company tries to innovate outside the insurance company. Maybe we're damned by knowledge. I don't know, but I can't do that because of ERISA, or I can't do this because of the ACA, or maybe state insurance law. And I'm not saying get rid of all the laws because then I don't have a job. But I do think we need to make the laws rational.
Dr. Drew, that is really interesting, and we need to make it rational. But the counter argument to that is that we're dealing with consumers' health, and we need to be responsible. We need to audit and vet every single touch point to the patient's care, because it's their lives, it's their health. So what is the counter argument, and how do we find that fine line between having simpler regulatory issues versus having consumers protected?
Right. So counterpoint, lawyers love that, by the way. Thank you. What I would say is, first of all, our focus is on the consumer. We don't want to do anything that would harm the consumer. Well, as I'm talking about, don't protect the consumer. And what do we do to fix that? Well, it's a little bit like social determinants of health. How do you start over? Well, if we could get Congress to actually say we're going to do some omnibus fix to ERISA or to the ACA, well, ACA, you know how that goes. I think it starts at the federal government, and we can do a lot at the regulatory agencies with guidance and regs and sub-regulatory guidance, but probably not enough.
Do I get to just bring it home? Is that oh, thank God. So I'd say I'll just touch on three things. And one was related to sort of this regulatory piece and the price of stuff. So an example might be that we contract with durable medical equipment companies, right, to provide maybe a knee brace or an ankle brace or something like that. The member might say, and we know they're a good company, we know it's a legitimate brace, we know it's made well, it's not going to break on them and everything else. Person can say, well, I can go to, anyone works for Amazon, I'm sorry. I can go to Amazon and just buy it there for a third of the price. But you don't actually know what you're getting when you buy things from, has anyone bought something from Amazon where they go, oh my God, what did I get? And so for us, from a regulatory standpoint, we wouldn't want to send someone to a place where we can't verify that, what they're buying is there. So that sort of adds some pieces to the cost. The second thing I would say is about data, and we were talking about that before. There will be a lot of people aggregating data. Employers usually have 10 to 15 different types of benefits available to members. Pharmacy benefit, dental benefit, vision benefit, medical benefit, EAP, on and on and on. If you have 15 of those things on your phone, and then you probably have another 4 on each one, you're not going to use them. So we will see companies come in and do a lot of data aggregation of a bunch of those things so they work together. The important part is I want to take that information with me because I'm the consumer. So if I have a different vision plan, I still want to have that information, whatever that might be. If I have a different medical plan, I want to have that. My medications change because they decided to change their, pharmacy benefit manager. I want to have all that thing in my one place. And maybe that's the Microsoft Health vault, and probably it will be something else over time. And then the third piece is just if you're really looking at a place that people need, may want to focus more on, musculoskeletal health typically is the highest cost category for most employers, and where they spend a lot of their money, and where they get very excited with us about, gee, it's really high, what do we do about it? And when you look at it, if you looked at that whole category, physical therapy typically is a very high cost in there. So and we get a lot of people that call us all the time. So this one company called me and I listened to them, which I will do. There is a way to figure out my email on there. There's a dot and then there's a regents.com after my name. And I would actually probably answer you, but I may not answer you in 5 minutes. What they did is they said, you know what, physical therapy is important. We know that people go every 2 to 3 times a week, maybe. We also know that they don't do anything between those times, right? In general. And what happens is it takes them a long time to recover because they're not doing that. And we don't even know, even if they're doing the right exercise, if they're doing it correctly. So they partnered with, I can do it in 2 minutes. They partnered with, I believe it's a technology that Microsoft gaming system, the Kinect system uses, where you can see people move, right? They built a device that actually looks at you and sees you. So they have one visit, and Duke just did the study and published it. One visit with the physical therapist, figures out what, you got to do these 5 exercises, here's your regimen, you got to do them every day, you got to do 3 times a day. You stand in front of this thing, now it sees what you're doing, so it records that you did it. It also gives you immediate feedback if you're doing it correctly or not. It sends that information to your physical therapist, who now can see that, yeah, you did 20% of them correctly, or you didn't do them at all. And if you don't do them, they can actually pick up the phone and call you. And if you have a question, there's a screen on there. You can actually do a telemedicine visit with them. I find that one really exciting. Maybe not from a health plan standpoint, but from a provider standpoint. If I want to expand what I can do as a provider, and if I'm a physical therapist, I could do that, and I get better results, and people got better faster. And they literally did one visit, and then they just took the device back when they were done, and they got better. I mean, that's a really cool thing that I would like to see more of.
Yeah, I think everybody hopes to see more of that coming in. There was so many cool questions coming in. I apologize that I couldn't ask them all. We have 5 minutes to get to a few audience questions, so feel free to ask your questions that I couldn't get to. Some of them were really, really cool.
I know I had a couple lined up from the last Q&A.
What is your take on, as we look ahead to say the 2020 elections, we talk about the inefficacy of policy making, especially at the federal level, and the fact that most often providers are not at the table, payers are not at the table in making these decisions. But now we have the decision.
Yes. By the way, they are 100% at the table. Yeah. In the form of lobbyists.
Well, yeah.
Yeah.
So when I speak of provider, I'm with the King County Medical Society. Doctor, welcome, by the way. We are so thrilled to have you as a member. So we represent, when I say provider, I mean the actual doctors. And if we look at the curve, administrators, doctors are flat. So, but when we talk of single payer, Governor Inslee's proposal, for example, when we talk Medicare for all, what is your take on what that means for the landscape, how that may hamstring innovation? Because we've seen in so many other fields, then it becomes a race to the middle as opposed to trying to bring in new innovation. We see it in education, for example. What do you think that is going to mean if we actually begin to move in that direction for you, for physicians, for innovators?
Sorry, I'm rooting for that, actually. I would like to not have to worry about paying for my healthcare coverage for eternity. No, is that due to them next to me? No, it's due to a runaway freight train.
What does it do to us?
What does that do to you?
Single payer system.
Well,
Maybe we can answer that.
Yeah. Let me finish. So I'm rooting for that. I have my own visions of what that looks like. but I would happily turn myself to focusing on a different type of a problem. If it was guaranteed coverage that people could walk into a clinic and be seen, no matter where you were, what your age was, what your income level was. I truly, truly believe that you should have access to care. Yeah, I mean, our statistics in this country sort of speak for themselves. Longevity, maternal rate, yada, yada. So, okay.
I'll start with my dad. My dad is 77 and worked hard in lumber mills in Southern Oregon all his life, saved money, so he's living well in retirement. But of course, he has Medicare, and he was really critical of the ACA and Obama and socialism until I pointed out Medicare is socialism. Then we just decided not to talk about it anymore. So when you say single-payer health care, you're talking, there's a whole spectrum. Bernie Sanders says single-payer. What he's talking about is nothing like anything in the other countries with single-payer. I think it's Politico has a really good article on this that goes through what other countries actually have. Nobody has a perfect system. Some may be better than others. But if we go to Medicare for All, which is probably the closest we can get to a single-payer system, somebody still has to process that claim and set up contracts with the doctors and manage the care and get in the way, or else it just doesn't work. Single payer isn't just a panacea. It's just a different way of solving the problem. My personal thought is maybe it's a better way, but I'm not sure if folks would say Medicare has been a great way. So you fix one thing, you break three others.
Can I put a different P hat on? So I can put a provider hat on. Is that okay? Yeah. So I think Medicare for All. No one knows what that means. That's the first thing, right? We say it. We go Medicare. That must be something. Maybe is it single payer? What is single payer? Who's the payer? If you look at other countries, they all do things differently, right? So from the provider standpoint, if you say Medicare for All, the concern is you're going to price fix everything that I do, right? You're going to pay me at Medicare rates, which don't cover my costs today. And so all of a sudden, how are they going to manage their practice, the hospital, whatever, when they're getting paid less than what it costs them to do business? And so I think that's a big concern. The second piece is who administers it, right? So Medicare fee-for-service, they can administer Medicare on a member basis for about $60 per person to pay all the claims. We do it and they go, see where it's only 5% of the premium, right? Well, we're used to doing that at about $30 or $35. So we can actually do it a lot cheaper as an insurance company than Medicare fee-for-service, and we can put in a bunch of other things. So other services like a case manager or buy some of those other things. So what you see in other countries like Germany, yeah, they have a universal coverage, good. It's a government-sponsored program, good. And then they have multiple different insurance companies that then compete for that business to be either more efficient, better member experience, better provider experience, all of those types of things. You don't want to stifle that innovation, but we got to figure out I think we have to have the discussion about what Medicare for All really means and how you're really going to fund it. And because no one's really talked about how it gets funded. Yeah, I think it could get funded pretty easily when you think of all the costs that we put into from an employer basis and everything else. And but we need to figure out what is the real model that we're talking about, and I don't think anyone's really politically it doesn't sell real well.
It will take a few presidential debates to get the funding needed.
I don't think it'll even come up there. So
any more audience questions?
Yeah, I know there are a lot, and we're out of time. So I have one more question, but Hannah, if we have people send their questions to Poll Everywhere right now, can we accumulate all of them and maybe categorize them and see if you all can write a follow-up? Is that okay? Okay, so please, everybody who didn't get to ask a live question, send your question to Poll Everywhere now, and then we'll send a follow-up in the next couple days. All right, one more.
Hi, Carol Redfield from Aging Options in Seattle Pacific. we know that there's a lot of money that's spent towards the latter part of living, aging. So how much innovation is being used or covered by insurance, maximizing, clients can maximize the insurance coverage in terms of, you know, we know about the gym, but silver sneakers is not evidence-based if you look at NCOA, and yet all the all the evidence-based stuff is not covered. How much of the coaching from insurances are really by people who are scientists versus somebody who's just been trained for 10 weeks? You know, that kind of things, because when you look at, I'll bring up Aravel just because we're looking at them as a partner. They have 60 nutritionists looking at all biomarkers. And you want to be able to have some efficacy down the road with coaching, not just, oh, how are you doing? I'm just your accountability partner. How much efficacy is being looked at and how much money is being paid for people like care managers who would look at how can we get your house ready for when you want to age? How can we have you go to rehab centers and look at the ones that you want to go to so it doesn't take you all the way to nursing home, but back home? How about advanced planning? Not so much advanced care planning, but planning for someone speaking for you so you can get back home versus the 70% that end up in nursing homes. So these are softer skills versus the digital, but those are all cash-based, not covered by insurance. Why are we not spending money for upstream stuff so that downstream would be changing the marker?
I don't have a good answer, right? But part of it is because we've been, mirrored in this medical care model, and it's an illness-based model, and that all happens to be downstream. And when we have rules, then it makes it hard for us to get upstream. But all those things are really important. And I think the piece, the other piece you didn't mention is sort of caregiver support. So a lot of those folks have, caregivers that also need support in terms of how they're managing those things. We have foundations, and most health plans do that help fund some of those things. But no, it may need a different mechanism. Maybe that's Medicare for All, that would actually help get us a little farther upstream.
So the reason for that too is because people spend an average of 2 years on a health plan, especially at the commercial level. So a lot of those services you're talking about is once you actually hit Medicare. So there's not a whole lot we can do. But you're on an average of 2 years. So one of the things about the Hep C drug that's awesome is that it cures hepatitis C, which means that in 10 or 15 years, you don't have to have a kidney transplant. And in 10 or 15 years, I'm not going to be on the same health plan. They don't care what happens to me in 10 or 15 years. They're really worried about, the next couple of years. And that's what my employer is worried about. And so the idea of this employer-based system that is not going anywhere in the next decade, as far as I can tell, that's really a downfall of that. Is it's every 2 years people kind of churn through, and if you aren't switching jobs, it's your employer changing carriers, and so that's the math that's being done.
I want to add to your list mental health. It's great to find someone to have a conversation with someone who's elderly about what their living conditions need to be. They may not want to talk about it. They don't like to think about dying or needing to be in a place without stairs. Personal experience, maybe. And then the other is just navigating and helping the elderly find the right providers. And, I just get call after call. The provider didn't know this, and now this has happened. And, sometimes I've helped kind of direct, like, I think this is good, and then it turns out it's not. And I think that based on the senior citizens in my life, they're at a total loss of how to navigate that system. I would just add those to your list, but I don't have an answer either.
Thank you. And with that, I would like to thank our amazing panelists and Cambia for hosting the 5-point series. And thanks for the amazing questions. And
I want to add just one more thing. Also, thank you to our panelists. And one of the questions earlier was, how do you get access to payers? That's one of my jobs at Cambia Grove, is to give you all access to the 5 Ps. And we do that through these types of events. And we have office hours with payers, so you can register for a 30-minute one-on-one with payers. We do that about every other month or every month. We have a roundtable this month coming up with payers. So that's my job, is to give you access to payers. So feel free to reach out to me, jessica@cambiagrove.com. Pretty easy. Also, if you have questions about policy, there's a lot of regulatory talk tonight. We have our Policymaker event coming up on April 3rd. So please join us for that as well. And thank you, panel. Thank you, Sina. You did a great job. And thanks all for coming.